everybody. So today what we're going to go through is co-occurring substance use disorders and mental illness. And this will be an introduction, meaning that we're going to cover this topic at 10,000 feet so you can see the landscape and the terrain. But of course, you can go into any of the nooks and crannies for the specific disorders quite at length. We don't have any disclosures, and we're hoping by the end of this didactic, you'll be able to appreciate how to differentiate between a primary addiction and substance use and an independent psychiatric illness. You should also be able to learn the comorbidity between substance use disorders and various psychiatric illnesses, as well as you should be able to construct a treatment approach for dual diagnosis patients with opiate use disorder and any of the other treatment disorders as well. And so in terms of co-occurring disorders is synonymous with dual diagnosis. And so if you look at it statistically in the United States, you can see that 44.5 million adults had a mental illness, 19 million had substance use disorder, and overlapping was 8.2 million people. And so there's quite a few. So the probability that you're going to run into these patients through your clinical experiences is high. And if you look at serious mental illnesses, things like schizophrenia, bipolar type 1, you have significant overlap as well. In this data from 2016, it ranks it at 2.6 million. Now, basically, if you look at the numbers from both of these, the takeaway point should be that if somebody has a substance use disorder, the odds ratio that they're going to have a primary psychiatric disorder is really high. It's the same thing if they have a primary psychiatric illness, the odds ratio that they're going to have a substance use disorder is quite high. And if somebody has one addiction to a substance, that in itself makes them a lot higher to have a secondary or a tertiary substance use disorder. And so to put some numbers to it, one study showed that people with substance use disorder were 4.5 times greater at greater risk for having an underlying psychiatric illness. And it was the other way around too. If they had a psychiatric illness, there was a equivalent risk of having a underlying substance use disorder. And so basically, if you're picking one up, you should screen for the other. That should be the takeaway home if you just look at the statistics. Now, in terms of prevalence, they're quite high as well, with schizophrenia being the condition that has the highest percents of lifetime substance use disorder. And what you see is a spectrum of percents for almost all the substances. Does anybody on the network want to guess why OCD has the lowest percent for prevalence of developing a substance use disorder? Well, if you were thinking, yes, it's going to be hard for me to make this Kleenex box and this remote parallel to each other when I'm drunk, you're absolutely right. So OCD is a disorder about control. So it's hard to be in full control if you're totally wasted on cocaine. Now, out of all the substances, alcohol ranks the highest, and it's probably due to high accessibility and how it's kind of ubiquitous in our culture, ranging from, you can find it in almost any store. If you sit down to eat a meal, the waiter or waitress will ask you, what would you like to drink? And so it's not a surprise that alcohol is seen the highest. Now, if you look at the downstream effects of what's happening to people that have dual diagnoses, it's basically poorer outcomes on any cross-section that you look at. And so they're gonna be relapsing in depression and having psychiatric exacerbations a lot more frequently, and this results in more psychiatric hospitalizations, more suicide attempts, the more family problems. If you ever talk to a family member of one of your patients that's struggling with these conditions, they'll easily attest to how stressful it is. Sometimes they won't sleep, they don't show up, they go missing. And so what you want to keep in the back of your mind is if a family member is bringing them to their appointments, the family member may need resources too, such as going to Al-Anon or a referral to NAMI. But all of these things, especially put together, cause a significant amount of suffering, and it's good to be conscientious of them. Now, in terms of assessing it, it would be a shame to put a teenager or a young adult on high doses of antipsychotics if the hallucinations or the paranoia that they're having are coming from cannabis. But sometimes the symptoms are overlapping each other, and so we need to have an approach to be able to wedge apart these two, and so that we can pair the treatments correctly with what conditions they may have. And so if your encounter is with the person that's intoxicated, it's always important to screen for safety. People have a tendency to have higher rates of completed suicides and attempts, as well as homicides when they're intoxicated. It's one of the risk factors for a 15-point assessment. The substance may be making them medically unstable, so we need to make sure that their vital signs are within the stable range. If they're not, we need to get them to the appropriate care, and then therefore attend to any medical symptoms. They may be going into withdrawal thereafter, and some of the withdrawal syndromes can be lethal. Does anybody want to use the chat box to mention two substances that can be lethal for patients withdrawing from? Right now, you're on point, but yeah, so benzodiazepines and alcohol can be lethal when people are withdrawing from them, and so imagine, to give a visual example of this, imagine that it's summertime and we're all in the pool, and somebody's pushing a beach ball down underneath the water of the pool. And so in this example, the hands that are pushing the ball down are alcohol and benzodiazepines, and the ball itself is alcohol. And so if we push it down and then we remove the benzos or the alcohol, what happens with the beach ball? Exactly, it springs up violently, and usually that's what happens if you put if somebody's on a central nervous system depressant and then you abruptly stop it or remove it, they get an excitatory wave of neural activity, and that manifests as a seizure. Sometimes it's lethal, and so we definitely don't want to miss that. Now, in terms of making the actual diagnosis, sometimes it's just not the best time to try to make the diagnosis while they're intoxicated. All right, now where the art comes in and the highest skill set is to be able to distinguish and differentiate between if it's an independent psychiatric condition or if it's a substance-induced mood state. And so we have a couple ways that we can distinguish them. And they're important because they both have different treatment trajectories. And so if it's a substance-induced condition, and it could be a substance-induced anxiety disorder, substance-induced psychotic disorder, substance-induced mood disorder. These are disorders that are usually related directly to the substance that they're abusing. And it'll usually resolve once they stop using the substance. The key point is that they can resolve at different time frames. So for example, if somebody is becoming paranoid because they're smoking methamphetamine, it may resolve immediately when they stop smoking meth. It may take an intermediate amount of time, or it may take several months for the symptoms to resolve. And so the different substances all have different rates of this happening. Also, if it's independent psychiatric symptom, this is one that's going to be present when they're not using any substances at all. And you may say, well, how long does that have to be? We have slides that are going to be coming up, but as a rule of thumb, 1 month should be sufficient to differentiate the two. The symptoms are also not related directly to using alcohol or cocaine or heroin. But you may say to yourself, well, they seem like they have major depressive disorder and they're also using a lot of alcohol. So how can I distinguish those two? And so we have other ways to do it also. The biggest one to tell if it may be substance induced is, did they have any symptoms that preceded their substances? And so that if the answer is no, they didn't have any depressive symptoms before they started using alcohol, and they don't have any when they're having periods of sustained abstinence, that means that the depressive symptom that they're happening and experiencing is probably coming directly from the substance. And then also, you'll see a correlation when you take your history that they're saying they're having these symptoms during intoxication, withdrawal, and that those symptoms start to improve or go away once the substances are out of their system and their brain had a chance to kind of reset itself. Based on what I'm saying, usually you need to have longitudinal contacts with the patient, and this always can't be done on the first encounter. Now, if it's a separate psychiatric disorder, you can use those same variables that I was talking about. So key questions are to ask if they had any of the symptoms of that psychiatric condition before they started using the substances. And here's an example. So did they have any paranoia before they used any meth or cocaine? And if the answer is yes, that means that they may have an independent psychiatric condition, and when they started using substances, it made it a lot worse. Other things that we can look for is genetic preloading, and this can include getting a family psychiatric history. Substance use disorders have a genetic component, but so do psychiatric disorders, and so we want to get a good family history. And then we also want to concentrate on what symptoms they're having and the quality and the intensity of the psychiatric symptoms during periods of abstinence. And like I said, 1 month or longer is usually an adequate time frame in order to do that. And so we already kind of talked about these, but when you reference your slide deck, these are the key things that can help you wedge if it may be a primary endogenous condition or if it may be coming directly from substances. All right, this slide is more for a reference point for you to look back on, so you don't have to memorize the information I'm giving you, but it gives you different ways and points in a form of a table that can help you wedge apart if this is a primary endogenous psychiatric disorder or if it may be coming directly from a substance-induced disorder. All right, now I wanted to go over a couple of substances with these next slide sets because they're important. Sometimes if you see somebody on a certain substance, it may mimic a psychiatric condition perfectly, but there's a couple things that you may be able to observe that'll help you differentiate the two. So for example, if you're interacting with somebody that's intoxicated on alcohol, they may have mood fluctuations, they may be belligerent, their attention and concentration may be impaired, and that has a certain pattern with different psychiatric disorders, but you wouldn't expect to see slurred speech, incoordination, things like nystagmus. Does anybody on the network know what this is, nystagmus? You were thinking that that's when the eyes have trouble adjusting when they look peripherally, you're right. And so that's why when you're rolling down Central eating ribs, and you see somebody pulled over by the police are moving their finger like this. And then if their eyes are going like that, yeah, eyes bouncing like that, that's nystagmus. So you don't expect that if people have a mood disorder. So the ones in red are ones that can overlap with psychiatric disorders. The ones in blue are ones that you wouldn't expect to see from the substance itself. And so let's go to stimulants real quick. And so has anybody ever seen a patient that's manic? Do they have bipolar mania? Well, if you do, it looks exactly like somebody that's just did a big line of cocaine, maybe like a Motley Crue line, where they had a straw that had one for each nostril. They're gonna become hyperactive, they're gonna become hyperverbal, they're gonna have psychomotor and kinetic agitation. You can't, basically all these things that are in red can happen. What you wouldn't expect to see in a patient that has bipolar mania is vital sign dysregulation, mydriasis, which is where people's pupils become really large, as well as some of these other symptoms, especially the cardiac symptoms. If they're going through opiate, or if they're going through stimulant withdrawal, this can mimic things like bipolar depression or MDD very closely. And so the cocaine and amphetamine withdrawal is more difficult to differentiate. If somebody's using cannabis, some of the overlapping psychiatric symptoms they can become more withdrawn, they can develop amotivation, they can become anxious and paranoid. And this is especially true if people are using cannabis products that are really high in THC and low in CBD. And so if any of you have ever tried to get somebody to quit using cannabis, it can be extremely difficult. So as a form of harm reduction, they may not be aware that those potent THC products are causing anxiety and paranoia. So what you want to do is try to get them to switch to a strain or a concentration that has CBD in it, 50 or something that's really high in CBD, cannabidiol, and low in THC. That could be done as a form of harm reduction. But you're not going to expect to see red eyes, tachycardia, or coordination problems if it's just a primary psychiatric condition. You can refer what happens with withdrawal. And if we look at opiates, opiates can cause dysphoria. They can cause psychomotor slowing. They can cause agitation. And then somebody's withdrawal, they can get really dysphoric and irritable, have a lot of anxiety and insomnia. And these have a lot of psychiatric symptoms to primary psychiatric conditions. But what you don't expect to see are pinpoint pupils, slurred speech, respiratory depression. And so these are some things that can be used to differentiate if somebody is really going through a psychiatric problem or if they're experiencing the direct effects of a substance. Now, nicotine is, nicotine withdrawal will basically kind of manifest itself like with some of the symptoms of a mood disorder. The one withdrawal symptom that you don't see with a mood disorders is somebody's heart rate slowing down. And nicotine is one of the few drugs that actually has that phenomenon. And so now that we've used our new techniques to differentiate if this may be a co-occurring disorder or if it may be a primary substance disorder or a primary psychiatric disorder, we can start pairing it with the appropriate treatments. But the one thing to remember is that if it is a co-occurring disorder or a dual diagnosis, we have to perceive them as holes in a ship. And so if we plug up one hole in a ship that's leaking but not the other, what happens to the ship? That's right. It's going to the bottom, or somebody's spending all their time trying to get all the water out of the ship. And so we have to treat the substance use disorder, and we have to treat the primary psychiatric disorder at the exact same time. Otherwise, it's going to be like plugging one hole of a ship that has two holes that are leaking. And so there's been a paradigm shift on how we approach this. And so the biggest one is to do what I said and treat these conditions simultaneously, not in sequence. And so we no longer wait 6 months for them to be sober for 6 months before we agree to treat a psychiatric condition. And so an example would be maybe a primary care physician may tell a patient, well, I can't treat your depression until you're sober for 6 months. But could you imagine being left with untreated depression for 6 months, a half a year? If you need to grasp what major depression can be like, has anybody on the network ever had their heart broken? Well, if you haven't, you're very lucky. But I'm going to raise both of my hands because I have bad luck when it comes to relationships. But basically, that can mimic a lot of the symptoms of major depressive disorder. And it just hurts, and it gets in you, and you don't want to get out of bed, and you don't want to talk to anybody, and you don't want to eat, and you can't go to sleep. Can you imagine going to your doctor with those symptoms of major depression and them telling you, we can't treat you, buddy, until you're sober for 6 months? And so this man, Mark Shuckett, who's one of the leaders on the forefront of dual diagnosis treatment, revised it, saying that 1 month of sobriety is enough to distinguish if we should start the antidepressant. And usually what you would expect is as somebody gets away from alcohol or substances, the psychiatric symptoms will improve, but they may not fully go away. Now, if they worsen while they're sobering up, that means that treatment needs to be started almost immediately. Sometimes they need a higher level of care too, including consideration for hospitalization. And so one thing to remember is just because somebody's using substances doesn't mean that they meet they have a substance use disorder. They have to meet 11 of the criteria within a 12-month period, and these criteria have to do with impairment. And so just because somebody's doing risky behavior with a substance does not mean that they need a substance use disorder at that time. But they should still receive a brief intervention because they are doing risky behavior that could lead to development of an addiction. Now, when we take steps to treat the dual diagnosis, what we want to do is we want to consider psychotherapy first. And so just to line this in context, there's a pre-step that's not in this slide, and we need to get them through the withdrawal syndrome first, especially the ones that could be lethal. And so after we do that, then we want to consider using psychotherapy as a first-line treatment. And they have manuals that are for psychiatric conditions and ones that are for addiction conditions. And a lot of them involve relapse prevention skills training and cognitive behavioral therapy, but they have manualized therapy for both of these. Step 2 would be to see if there's a consideration or a need to use medications. And if we do, they go really well and complement psychotherapy nicely. Sometimes they can even help patients engage more in therapy. You may want to consider this as step 1 also if their symptoms are very severe. Okay, I have a question. Let's take a look at a question. All right, so one of the questions is, when I'm inducing people on buprenorphine, patients that are in withdrawal, I usually wait 1 to 2 weeks to treat. Do I need to start treatment the same day as induction? And I would say it depends. If they have a known psychiatric condition, you may want to start treatment, or at least the anticipation of the treatment. But I would say it's always best to stagger medications, meaning that if you start 2 medicines at the exact same time and they develop side effects, you may not be able to differentiate which one caused the side effects. So I would always recommend starting medications, but you want to give them preemptive heads up that you're aware that they're suffering from this condition and that you may need to use medication. So you want to give them the prompting that you're not ignoring it and that you're getting ready to set that up also. But I would say like the most important step in that order would be to use the buprenorphine first and then the antidepressant next, because the antidepressant is going to take several weeks to start working. The buprenorphine is going to start working that same day. And so most likely you'll have adherence and they'll come back. I hope that answers your question. Thank you. It's very relevant. Now, you want to be conscientious because like the example we gave with the heartbreak, these conditions and these symptoms cause a lot of suffering. And so that was the one for depression. And I could give you plenty of examples in terms of visualizing and imagining that you have anxiety from an example, but I won't get into it right now because I don't want to torture your guys' minds. But you want to be conscientious and empathetic toward their suffering, and you never want to trivialize these symptoms that they're going through, because we don't know what extent that it may be penetrating into their lives, because these kind of conditions can affect somebody psychosocially. It can affect them in terms of their family interactions. It can affect them spiritually. And often we can't go into all these domains on the first or second encounter, but they're very relevant. When we are treating people, we want to have awareness of the different components for medication-assisted therapy. We had a question that involved buprenorphine, which is the active ingredient for Suboxone. But the other FDA-approved medicines that we also have and we want to use are methadone. Now, methadone and Suboxone, what they have in common is they both have half-lives that are greater than 24 hours, meaning that it takes the body over 24 hours to break them down. So from one day of dosing to the next, there's drug lingering in their system, and that's what breaks them out of the withdrawal cycle. And so that's why they're important. And then there's the naltrexone, which is the opiate blocker. And so we want to be conscientious of using these ones. Now, the studies have shown that you can safely use psychiatric medications with similar efficacy But there's a couple drug-drug interactions that we want to avoid. And so for the biggest drug-drug interactions come from combining methadone with other psychiatric conditions. And so the two main drugs, just if you want to write them down as pearls, would be if somebody's on methadone, do not use Seroquel. The Seroquel can add with the methadone and make their heart beat abnormally, and also inhibit metabolism of both the Suboxone and the methadone, so they can have unstable wavering levels of both drugs, and it can make them accidentally overdose. In the terms of the antidepressants, you want to avoid using Celexa or citalopram, and these are medicines that can be used for affect spectrum disorders, anxiety spectrum disorders, OCD, and PTSD. The citalopram can combine with methadone to cause a heart arrhythmia called QTc prolongation. The ones we want to try to avoid are going to be ones that have that are controlled substances, and the biggest group for the psychiatric medicines are the benzodiazepines. The next biggest are the stimulants, and so we want to avoid using them, especially as first-line medications. Sometimes it is important to use them, but if we do, we want to have things that are set up to help us regulate how they're being used. So for example, if you're going to start somebody on a benzodiazepine, it's pretty useful to have a benzodiazepine contract, meaning that they have to agree not to misuse the medicine, run out early, that medications won't be refilled if they're lost or stolen, that they won't crush and snort them, they won't obtain them from other providers or diverted sources, that they'll agree to pill counts. You can also do things like prescribe 1 week at a time and then add refills so they have a limited supply, or you could use a family member to hold them. But if we're going to use medicines, especially in the primary care setting, we want to have a basic knowledge of some of the antidepressants. A lot of these psychiatric disorders that we covered are connected through the serotonergic system. So that's why you're going to see FDA-approved medicines that have overlapping conditions. And so a lot of these medicines that are listed on this slide are meant to bump up and boost serotonin levels. The exception to that would be valproate, which comes from valerian root, and the more common name of it is Depakote, and that's used for bipolar stabilization. We're winding down the talk now, so I did want to show you two pie charts just to let you know that the majority of the people that do have co-occurring disorders aren't seeking any treatment. And if you go back to the slide that had all those poor outcomes like suicide attempts, homelessness, family problems, you can see that there's a great amount of suffering. And so that's why we wanted to thank you all for joining this network, because that means that you're in preparation of getting ready to do something and arm yourself with the appropriate education. Referring to me is always a possibility, but the majority of the treatment for the dual diagnosis isn't happening from an addiction psychiatry specialist. If you look at the severe mental illnesses, the percent is higher because their needs are more, but still treating the substances and mental health, the primary psychiatric disorder, are usually not happening simultaneously, and that's what needs to be done to get patients the best outcome possible. And so always with a patient that has both a psychiatric illness and a substance use disorder, they're going to be extremely complex, difficult to manage, and so it takes a village sometimes. And so the integrated approach is going to be key for getting the patients the best outcomes, and getting them deeper into remission is important. And the goal should be getting them into longer and longer periods of sobriety and remission for the psychiatric illness and the substance use disorder. And so it also has to do with things like getting sure that they have access to healthcare, that they have housing, that they have a sense of purpose, as well as a community that can help support them. And not only the patient, but also their family members. That concludes it, and we'd like to open it up for questions now if the network has any.